So the ECHELON-2, as you know, is the only, probably the best studies in T-cell lymphoma on the front line. CD30 has been a divider in the sand in T-cell lymphoma. Is such a heterogeneous disease with at least 30 different entities, and CD30 has become an enabler for better responses, better therapeutics. And Brentuximab Vedotin is an antibody drug conjugate that uses CD30 as an entry point to drop the chemotherapy MMAE. The ECHELON-2 was designed to compare what was the standard CHOP in comparison to the addition of Brentuximab Vedotin, of course, minus the Vincristine, so it's a CHP BV regimen. We have the 5-year data, which is presented at ASH last year by Steve Horowitz. And the initial data cutoff looked at the primary endpoints of progression-free survival, which it met. And there's a huge difference between the patients who received CHP BV and CHOP. It's a 40-month versus 20-month difference. And the PFS, the median PFS has not been reached. At that time, the initial data cutoff in 2019, and the 5-year and the overall survival was also met, which is a secondary endpoint. The 5-year data just enhances those aspects. The response still maintained for patients who received CHP BV. They maintain a response, and there's still the benefit of reduction by death or disease progression by anywhere from 30 to 40%. So the updates in ECHELON-2 are very promising. So for those patients with CD30-positive T-cell lymphoma, it's an option, even though the study had a predominance of ALK-positive and ALK-negative ALCL, which for the most part express CD30 100%. There are other subsets like the PTCL-NOS and the angiomoblastic T-cell lymphomas and a few others which also express CD30. And this study did have an inclusion to have many of these non-ALCL subsets, and you see responses even in those. And though the numbers were small, one of the questions that was asked in the study, while we met the primary endpoint and the secondary endpoint, was how many of these patients could be consolidated with a transplant. And a transplant is a big question. It's a question that a lot of T-cell lymphoma folks debate, the transplanters debate, whether it's the right thing to do for patients who achieve a complete response up front. And in this study, the investigators had a choice to send the patients to consolidation transplant. And this is an international study, but across the world, I would say about 20 to 30% of patients actually ended up getting an autologous transplant. And when we did a post hoc analysis of this set of the patients who went on to achieve a CR and then a transplant, we saw there was still a difference, a trend towards overall survival benefit in those patients who got a transplant. So the question often becomes, if they're ALCL, ALK positive, do you send them to a transplant? The answer is no. So many of these patients who went on to receive a transplant are ALCL, ALK negative, PTCL not otherwise specified, and angiomoblastic T-cell lymphomas. And you might ask the question whether ALCL, ALK negatives might need a transplant. And today, in lieu of several other biomarkers that might be helpful, such as DUS22 and others, I still think that you have to send the right patients to a transplant. Young patients who are chemosensitive, the ones who achieve complete response. PTCL-NOS and AITL, at least our institutional preference is to send them to a transplant up front. And this data just shows that even in an international data set, even though it's selected patients, there is a trend toward overall survival. So I think that's what the recent publication in Blood Advances show, that there is benefit in sending patients to upfront transplant.